Okay, well, that's it from me. I will now hand over to Councillor Sheff, who will introduce our speaker and take us through our lecture. Thank you.
Thank you very much for that, Ali. And let me start thanking you, as always, Ali, for that wonderful introduction. I am so delighted to welcome one of the most experienced and respected midwives to join us this evening, Professor Jacqueline Dunkley-Bent OBE. She was the first person to take on the role of Chief Midwifery Officer for England and is now the first Chief Midwife within International Confederation of Midwives, based in Hague, Netherlands, where she joins us this evening. This has been a truly pioneering career, and Jacqueline has shattered many glass ceilings to ensure that midwifery can receive true representation, both nationally and internationally. In doing so, she has been one of the loudest and passionate voices championing better care and safer births for our parents and babies. She has shone her spotlight on many different vital areas of care, including maternal mental health, better access to physiotherapy, and more personalized care for all families. This is barely scratching the surface of the many different areas Jacqueline has focused on throughout her career. This year, as part of 75th anniversary of the NHS, Jacqueline has also been recognized by the Nursing Times as one of the 75 nurses and midwives who have contributed in a significant way to the NHS. She's also the chair of Maternity Advisory Group for the Health and Race Observatory in England, a role which allows her to help combat maternal health inequalities. So friends, it is a real honor to have her here this evening for a question and answer session about her career and her wider views on maternity care. So Jacqueline, a huge warm welcome to you here in London on this sunny evening. I hope The Hague is also as sunny as London is this evening. Just looking out of my window, it is really is sunny, and I'm sure that a lot of people who are here joining us this evening will be grateful to be joined with you in company rather than enjoying the sunshine outside. Jacqueline, let me kick off with the first question first then. And I would be interested in finding out what first attracted you to nursing and midwifery, please.
Well, thank you, first of all, for inviting me to be with you. It's an absolute privilege. It's 7 p.m. here, so we're an hour ahead, and it's not so sunny outside here, but nonetheless, delighted to join you this evening. It's a really good question, and whenever I'm asked this question, I always want to say something amazing, but I'm going to disappoint you by saying that I didn't have some epiphany about becoming a midwife. I trained as a nurse, and after a year of nursing, at that time, you went into midwifery, and that's what I did. But what I do remember is that I wanted to be a part of that miracle of what for most is a miraculous experience, a very privileged experience. And I really wanted to be a part of that. So I'm sorry I can't tell you anything that's more inspiring than that, but that's how the career started.
Thank you. And talking about miraculous and miracles, and indeed you have been performing many miracles and doing amazing work. You have truly raised, Jacqueline, the profile of midwives, both internationally and indeed here in the UK. And I wonder, what unique insights or contributions do you think midwives have to offer for improving maternity care? Both here, of course, in UK as well as internationally.
Yeah, absolutely. And another great question. What I will say, and I'm always astounded by this, these data that I'm going to share with you now. And I have said this before, and I'll continue to say it, because I think sometimes we are desensitized from this. You know, global estimations say that there are 810 maternal deaths every single day, one stillbirth every 16 seconds, and 2.4 million newborn deaths each year. And so that's the size of the problem. Almost 95% of all maternal deaths occur in low and middle income countries. And those data are from 2020, and most of them could be averted, could be prevented. Now, the reason why I've mentioned those data is because if you have an educated midwife working in an established health system, they have the potential to save the lives of women and children. And that's saving the lives at a scale that's unmatched by other interventions. And you know, there's a study in the Lancet Global Health series that talks about the fact that if you have a midwife that's educated in an established health system, they estimate, the authors of this work, Andrea Nove and colleagues, estimate that you would avert 67% of maternal deaths, some 64% of neonatal deaths, and some 65% of stillbirths in 88 low-income and middle-income countries. So just thinking about those data and thinking about the impact that a midwife makes, it's somewhat of a no-brainer when we have these challenges globally. I think in the UK, of course, we have regulation, we have an established health system. And so if you have a midwife in that environment, you should improve maternity outcomes and experiences.
Thank you for that. Thank you for sharing those disturbing statistics, but equally, the statistics aren't that good here in UK either, particularly looking at Black British mothers who are up to 5 times or more likely than white mothers to die during pregnancy or within the first 6 weeks after childbirth. And Jacqueline, I wonder if you would be able to speak a little bit about why you believe this inequality exists, Liz.
No, and a really good question again. And I think if the answer was easy, the UK, England wouldn't be in the position that they're in, with Black women being 3.7 times more likely to die in pregnancy, brown women being twice as likely in comparison to their white counterparts. But what I will say is, and what I've learned, it's been integral to my entire career, listening to the experiences of women. If we listen to women, put women front and center, what they say is they're not listened to. Black, brown women, women from other ethnic minority groups, socioeconomically disadvantaged women, there's a common thread here. They say that they are not listened to or taken seriously when they share their concerns. This means that action and interventions aren't timely. And so because the actions and interventions aren't timely, this may result in loss of life or serious illness. Nobody can ever imagine that one would get pregnant and lose one's life. You know, so I do think that is front and center. I also think that access to maternity care and the timeliness of access could be improved, particularly for women who are not used to the healthcare system and understanding how one gets maternity care. I think we need to work more on access. And, you know, frequently we talk about difficult to reach. It's not difficult to reach. It's the fact that it's difficult. It's difficult for women to understand our complex system. So there's more work to be done there. But I do know that many maternity services locate their antenatal care, postnatal care in the community closer to home, and that does help in some regard. But actually, women die as a result of complications during and following pregnancy and childbirth. And most of these complications develop during pregnancy, and most are preventable or treatable. So, you know, that's something that we need to note. And other complications may exist before pregnancy, of course they may, and they are worsened sometimes during pregnancy, especially if they're not, if the risk assessment isn't appropriate and they're not managed as a part of the woman's care. So, you know, complications in terms of bleeding, infections, high blood pressure, unsafe abortion, etc. That's more from more of an international perspective in low and middle income countries, some parts of developed high income countries, I have to say. So I think that the reasons are multifactorial, but I would go back to what I started with. What women say, Black, brown women, women from ethnic minority groups, they say that they are not listened to and taken seriously. And when I look at the Embrace reports, the mother and baby reducing risk through audit and confidential inquiry, these reports allude to, especially some of the case histories, show that women share their concerns and challenges with maternity services, and they get sent home. They go back and they share their concerns, and sometimes they get sent home or they're not taken seriously. And the next time that they access, they are in a really challenging health situation, or indeed they might not make it back to the hospital. So, and I look at people like Serena Williams, who, even with her celebrity status, she wasn't heard, and complications ensued. So we have a lot to do in terms of who listens to who. There was some evidence way back 20 years ago that suggested that if you wore a hijab and English wasn't your first language, you wouldn't get the same information as somebody who was white, middle class, suited and booted, and was a lawyer, for example. And 20 years later, I still think we have much to do in the space of discrimination, racism, or even unconscious bias, if you believe in that.
Thank you for that very powerful reply, Jacqueline. And Jacqueline, of course, listening is hugely important, not just in maternity care, but I think in any situation. How do we begin to tackle that? How do we make sure that we are listened to? And how significant do you think racial disparity is?
I think there are many things that, for example, I know that NHS England, and that this was during my time there, in the latter year of my time at NHS England as the Chief Midwifery Officer, there was the equity guidance, and that was a framework for local maternity network systems to use to ensure that there was a levelling up of inequality and equity, so that every woman, and this is one of my visions, every woman who receives maternity care has the same experiences and outcomes as those who have the best. And so that guidance is one way, but it's a top-down and somewhat middle down. I think a charity called 5 Times More, a couple of phenomenal women who have some key facts and points and questions that women can use to engage with maternity services about their care. And I think what that approach does, it's a bottom up, it's empowering women to say, actually, this is what I want to know. And actually, I've got a follow-up question. There's something about empowering our communities to know that it's okay to ask questions. This is about their care. No decision about me without me. So please give me the information. So empowerment is absolutely key. So I think the two together, and also then, of course, this old adage, and it isn't necessarily old, but education and training. How many decades have we been educating and training people in relation to cultural competency, cultural sensitivity, the needs and wants of diverse groups, being kind, respectful, compassionate? You know, there is only so much training that can happen. So I think we need to ask different questions and have a different approach. And I've just given you a few examples there, but the equity guidance will assist, I'm sure, in ensuring that people have the right things in place to move the dial on this dreadful situation that we currently have.
And of course, Jacqueline, improving maternity care is very high up, as you quite rightly highlight, the national agenda at the moment, particularly following the publication of the Occident report. From your perspective as the chief midwife, what are the biggest areas of improvement apart from listening, apart from access that you have already referenced, that we need to prioritize over the coming years, please?
Yeah, I think generally, I really do believe in the Michael Marmot principle of proportionate universalism, which states that healthcare, maternity care, should be provided at scale and intensity that is equal to the level of need. And I always add pace into that sentence, because I think that pace is really, really important to every single person that comes in for their unique experience. Pace is important in terms of safe maternity care. So I think that, you know, universal high quality care is required for all. And then we do deep dives for those who are more likely to experience poor outcomes and experiences. But what I will say is that from all the reviews that have happened in England over the last few years, investment in maternity services is absolutely key. And it's not just about increasing the number of midwives and obstetricians, it's also about focusing on the culture within maternity units, the culture. And unless we have very senior people at executive level that walk the floor, do the temperature checks, understand what's happening within maternity services, then how can anybody be accountable for improving the culture and making maternity care safer? There's also, I think, thinking about the Ockenden report, the East Kent report, the Morecambe Bay report 7 years ago, the forthcoming Nottingham report, and just thinking about those reports and other softer intelligence. I think mutual respect between midwives and obstetricians is absolutely significantly important. There is enough work for all of us to do, mutual respect. And I remember working at Guy's and St Thomas's as the head of midwifery many years ago, and we had a mantra that was very much led by the obstetricians, and that was, we are equal to midwives, but we are different. And that mantra was equal but different. So every time there was a rotation of trainees, that was the mantra that was shared. And we all enjoy being a part of that and led together. So mutual respect. I also, when I was the chief midwifery officer for the NHS in England, one of my visions that I still hold true today globally is that staff should feel and be valued, respected, and invested in. If we want people to do a good job, then a hard job, then we need to value them, respect them, and invest in them equally. It shouldn't be determined by how you speak, your socioeconomic status, or the colour of your skin. I also think in this space of improvement that organisations, maternity services, hospitals, community centres, wherever we are in the globe, when there is a culture of being risk averse, fearful environments where people are thinking, you know, I'm going to lose my registration, so I'm going to be ultra safe, which creates sometimes unsafe practice. Risk averse environments, fearful environments do not foster safe sharing and learning environments. You know, there needs to be kindness and compassion. I do think that the government need to restore the student bursaries, student midwife bursaries, so that our student midwives have an enjoyable experience during their training, not thinking about, can I attend lectures today because I haven't got the train fare or the tube fare to get to university or to work. And what I finally will say is that my final point is none of the above matters unless we can sustain. We seem to not be able to sustain our greatness, and investment cannot be taken away once it's invested in. It must be sustained so that in 4 years' time, 5 years, 10 years' time, we haven't got women thinking, well, am I in the right place? Am I going to be the lucky one? They should be thinking we have great maternity services across England, and I'm happy about being pregnant and I'm not fearful.
Thank you, Jacqueline. Jacqueline, the culture that you talk about, valuing the staff that you have just referenced, how do we ensure that all those good practices which happens day in, day out in a great many services is uniform right across our different geographies, not just at the place that you have just talked about, but all over. So it's not a bit of a postcode lottery. Training you mentioned a while ago, education, you referenced earlier. How do we ensure that there is a degree, a level of uniformity, so that there is less of disparity, less of inequalities for great many of our mothers-to-be and mothers?
Yeah, a great question, and I think you're alluding to the unwarranted variation across England. When I think globally, the unwarranted variation globally, you know, in high income countries, women have a choice of water birth. Some are disappointed that they don't get the water birth because for whatever reason. And I could share with you, in sub-Saharan Africa, women might not even have a cup of water to drink during labor, let alone a cup of clean water to drink during labor, let alone have enough water to birth in. So there is unwarranted variation across the globe. In England, across the UK, there is unwarranted variation. We know this, that north-south divide that was talked about in the Black Report some 3 decades ago is very much alive today in some regard. And I think accountability, I think uniformity in terms of policies and guidance, health policy, how that is delivered, no policy about me without me. So really putting women front and centre, listening to them. Better Birth, the report of the National Maternity Review, some 8 years old now for England, had the voice of some 9,000 users of maternity services, midwives and obstetricians, who contributed to what those recommendations should be in that document. And I think it's really important that with all the guidance, with all the CQC reports, the HSIB reports, the Embrace reports, all the audits, a nice guidance, all the penalties, all the sequins, all this a virtuous world of all these items, I think that in the absence of accountability, then these things are implemented, and when things get a little bit challenged, sometimes they aren't always sustained. So I do think there is something about accountability, but giving people the resources so that accountability can work for women and families. we shouldn't be setting our services up to fail. And there is enough of all that stuff I've just mentioned, some great stuff that will really lead the way for safe maternity care. But for it to be sustained and equal in its provision across England requires that accountability, and it sits in the governance space as well, I think.
And for that safe maternity service and for that accountability and for all those aspects of inequalities that we've been talking about this evening, there is yet another inequality in form of the workforce itself, as the recent report from the Nursing and Midwifery Council highlights. And again, Jacqueline, I would be interested in knowing, you have already talked about valuing our workforce, our midwives, and those working in our maternity services. But what more can we do to ensure that we really do genuinely value those individuals, so that there is less of a turnover and there is much more positive and better outcomes for our mothers to be and our mothers?
Yes, yes, absolutely. And I think, you know, I think the answer is I personally think the answer is very basic, but obviously very difficult to execute and sustain. And to be valued as an individual, you know, even if we start with the appraisal, that's one. All we're asking is one meaningful conversation per year with an employee, one. And that one meaningful conversation should not be a tick box exercise that many would resonate with, as in tick box, that was a waste of time. It should be a meaningful exchange of how things have, you know, we know how appraisals should be, but do we execute them in a way that adds value to that person? Maybe not. So that one meaningful conversation, not a lot to ask. And I think, you know, just the continuing professional development, is that equally distributed? Are we looking at in maternity services the needs of a particular unit? How many staff have been supported to undertake certain programs of learning? For those staff that want to go on to higher education, are they being supported? Did they have meaningful conversations with their managers, and so on? You know, do execs walk the floor and familiarize and socialize themselves with their workforce? Or is there a glass ceiling that you never would see a trust board member? I know many trusts in England where the execs and the non-execs walk the floor. They do those temperature checks. They know what's happening on the invisible elements, the invisible elements below the waterline, you know, the iceberg below the waterline. They know exactly what's happening. And some don't go anywhere near their maternity units. And so how can they say that they truly value their staff? Investing through appraisal, continuing professional development, saying hello. Some people don't feel as though they're seen or even visible until they're being asked to work extra hours, etc. None of this is rocket science. And I think every leader and every manager would have been schooled in this. And if they haven't, they will know how they felt when they weren't valued, when they weren't respected, when they weren't invested in. They will know. And then you make a decision as a leader. Are you going to be an authentic leader and lead in an authentic way by valuing those people that you're leading? Or are you going to be like other leaders who didn't make you feel as good? You make a choice, don't you? I think you can make a choice.
Thank you. Let me bring one or two colleagues for questions. I've been hugging all the questions thus far, Jacqueline. Let me not be too greedy. Margaret, really good to see you. Margaret, your question, please. Margaret,
I'm here,
until
don't worry.
recently,
I'm here,
until
don't worry. But forgive me, I just have to do this. Hold on 2 seconds. Yes, I was just asking, posing a question about the term midwife. Seeing as we're looking at gender neutral, we're trying to encourage a more diverse workforce. Are you going to actually start looking at the term midwife? Because it's such an anachronism, wife, mid, female. And we know that most of the clinical teams are made up of all genders. So are we going to be looking at that?
That's a really, really good question. And in all honesty, no, we are not looking at that at the International Confederation of Midwives. So the ICM has the definition of a midwife. The ICM has the education competencies and standards. And we are not looking to change that midwife into anything else at the moment. It's a good question, and maybe it's time that we do, but at the moment,
yeah, I think midwife, you know, I say for me, fantastic, when I absolutely love midwives, but I think that we need to, if we really want to make the journey of moving on and make everything right across all the piece, we don't need to talk about Spain and so forth. We really need to look at every aspect.
Absolutely. Well, there's probably about 1% of midwives globally, but nonetheless, 1% must have their voices heard too. So good point.
Thank you. Jenny?
Thank you.
Thank you, Margaret, for your lovely question. Jenny? Okay. Jenny, good to see you. Thank you very much for joining us, as always.
Unmute myself. Hello, yes. So thank you so much, Jacqueline. And you've literally answered most of the questions I had, actually. But I still wanted to make an observation. And, you know, one of the things that really strikes me is when you say about listening. And in our work in Brent, we really emphasize listening. And there is something called the CNWL way. And for those who you might not know what CNWL is, Central and Northwest London NHS Foundation Trust, which is a mental health trust that serves the London Borough of Brent and other surrounding boroughs. And we've been working on inequalities for the last 3 years now as part of the Brent Health Matters program. And what we found was that we needed to listen and really listen to people without an agenda, and hear them in order to be able to help them. And having gone back over my own experience as a woman who lives in Brent, as a mother, as a Black woman, I found that, as you mentioned, listening was really important. In the early 90s, when I had babies, if I hadn't been listened to, I would have had real difficulties, because I was one of those women who always had complications during my pregnancies and at birth. And the first 2 times that I had my children in the early and mid-90s, I had a Black midwife, a Black African midwife, and you don't have that sort of consistency anymore. But I truly believe that if I didn't have that, I would have really had difficulties that would have been exacerbated compared to what happened. And then by the time I had my 3rd child in the early 2000s, things have changed significantly, and it wasn't for the better. And being a woman from Brent, I had chosen to go to a Westminster hospital because I'd initially lived closer to that area, but I was being given the option to go elsewhere. But I had to insist that I wanted to have my children in an environment that was familiar to me, where I thought perhaps I knew the people that would look after me much more effectively. But I was able to articulate myself, because at that time I was training to become a health professional myself. Therefore, it was easier for me to be able to advocate for myself and to be able to get the right care at the time. And luckily, despite having all complications during all of my births, I managed to, you know, be really well looked after. But in contrast, when I then took my sister-in-law to the same hospital to be looked after, as I said, things had significantly changed. We were turned away several times. She went into labor in the early hours. I took her to the hospital. We were sent away. I went to work, finished work, came back and took her. She still hadn't, you know, progressed in her labor, and we were sent away again. And this was the first time at birth, and because she wasn't listened to, she ended up having to have invasive procedures almost 2 days later because we were not listened to. And by the time we were listened to, was because I actually took out my NHS badge and said, if you don't intervene now, I'm going to have to really, you know, raise this as a form of complaint before we were listened to. So listening, cultural competence, cultural sensitivities, not being indifferent to people. Yes, a lack of resources, staff training, all of the things that you've mentioned are really, really important. But having that human touch is also much, much more important. And I felt that if I wasn't there, my sister-in-law would have really not been heard. And if I hadn't then like waved my badge around, things could have been a lot worse. And as you said, things that could be avoided could have been avoided. She didn't need to have a C-section if we had been heard. And this still happens, and it will continue to happen until we really do begin to listen to people. And the example that you gave of Serena Williams is something that I was going to give as well, because if Serena Williams, of all women, cannot be heard, then what hope do other women really have? It's really
Thank you.
I would say. So
thank you very much for that, Jenny. Really grateful to you for sharing that very personal but a very strong and powerful story. Thank you. Jacqueline, we have talked a great deal about listening and access. You may be aware, you may know that Northwest London has recently introduced a free mum and baby app, which is translatable in 5 top community languages, which helps, as I understand, people personalize their care and get information about pregnancy, birth, and beyond. Jacqueline, I would be interested in your views on how new technologies are being integrated into maternity care and what could be some benefits or potential drawbacks even.
Great question again, and we're all in this digital space right now. So I'm absolutely in support of digital maternity, and every woman has access. Asylum seekers and refugees have access to a mobile phone. And most mobile phones have the capacity to do most things. You know, people talk about having their lives on their phones. So why shouldn't they interact with their maternity records? That information belongs to that person. So why shouldn't they be able to access through their mobile phones? The drawbacks, I would say, may be an over-reliance on an app. As digital information, as we know, if there isn't good governance, it may well not always be up to date. I remember doing a booking in a maternity unit, probably only a couple of years ago, and the woman was looking at me as I was doing the antenatal booking, but she always looked at the app when I responded, and I asked her I asked her if she wouldn't mind telling me what she was looking at, and she said, "Oh, it's my mama care," and it was an app that was really telling her that I was saying the right things, which was quite disconcerting for me, but I was delighted that she was happy with my responses. So you know, could be a double-edged sword in some regard, but this is about the woman's journey. This is about the gender diverse person's journey. You know, just on a personal note, my goddaughter, about 6 years ago, was in early labor, and I didn't know she was in early labor. It was something like 6:30 in the morning, and I was on my way to work or getting ready for work, and she called me to tell me to check my WhatsApp messages. So she wouldn't tell me, but she told me to check my WhatsApp messages. I checked my WhatsApp messages, and what they said was that she thought she was in early labor. I responded on WhatsApp with some advice. She then sent a screenshot of her contractions and asked me what I thought. And what she'd sent me was a screenshot of a contraction monitor and timing app that did all that, monitor the contractions, time them, and then had a little chart. And I thought that was just, and you know, she was in her 20s at the time. So in answer to your question, why shouldn't we run alongside of modern technology? The mobile phone, I can speak into the phone and it will do anything for me. Why shouldn't maternity services keep pace with modern technology? As long as we have some good governance around the information that women are looking at, and we can give advice about the apps that are NHS England kite marked, for example.
Absolutely, but I guess a slight drawback would be perhaps potentially digital or technology poverty and access. We've talked about access and equality a bit earlier this evening, and I guess you know, there may be some issues around that, and I think. For me, if we are to, you know, go forward with that, we just got to make sure that nobody is being left behind.
Absolutely, absolutely. And I think many units have unique identifiers when a woman books, so they automatically will be included, and there shouldn't be any, obviously you're having to compete with internet charges. And I remember I have a vague memory of during the pandemic, during year one of the pandemic, toward the latter end of year one, the mobile phone companies waived their internet charges for those using maternity services, but don't quote me on that. But I do remember something about that. But digital internet poverty is something that we need to be mindful of. I totally agree.
Thank you. And Jacqueline, you clearly are a great ambassador for the midwifery profession, as we all know, and a great role model too, for that matter. How do you feel? How do you feel having that tag as a role model? And what advice would you give to young budding midwives?
Well, I guess I feel a sense of, you asked me how I felt, I feel a sense of responsibility, but not in a burdensome way. I guess that with great height comes great responsibility. So the more senior you are, you have that responsibility. But I don't feel as though it's a burden. It isn't difficult for me because I live the values that I lead by. I genuinely care about people. I genuinely I have some specific morals and values that I live by that assist me in how I conduct my leadership. So I do feel a sense of responsibility. My focus is always has been and always will be placing women, gender diverse people, babies and their families front and center of everything that we do as midwives. And I think, you know, sometimes when people are struggling, I always remind people that remember, it is a privilege, an absolute privilege to be a part of this, what is for most a miraculous journey, a significant moment in a life course, and the midwife is a part of that. So you know, and the joy and the privilege of being in that space. The advice that I would give to young people coming up, for those that are considering a career as a midwife, I would say it is the most rewarding experience. Absolutely rewarding. But ultimately, for those midwives that are currently midwives, I would say my advice would be your best, do your best, and always do what's right. And that's advice that was given to me from when I was knee-high to a grasshopper, my parents saying to me, you know, do your best, be your best, and always do what's right. And I would say that to those coming up. But I'd also say to those that are thinking about going into teaching, leadership, management roles, make sure that you have the appropriate education and experience, because with education and experience, you're able to navigate tough stuff well. And I can't overemphasize that. I did a master's degree in 1995 in health promotion, and I still use some of those principles today. you know, I did my doctorate 7 years ago, and I still use those principles for when I'm in a really challenged position. So that's what I would say to those younger that are coming up. And also, I think, let's be emotionally intelligent. You know, let's really listen to people. Let's really see people for who they are. Let's really step into the context of where they are, because it will bode well with you for how you move forward with them or with the agenda that you're trying to achieve.
Thank you. Tazzy has just put a good question in the chat. I'll pick that up in a moment. I do want to pick up a couple of phrases before that, Jacqueline, if I may. You talked about joy and privilege, and I'll come back to that in a moment. But let's just first touch on great responsibilities. And of course, you've had a great responsibility as the first ever Chief Midwifery Officer for England, and now a global Chief Midwifery Officer. And I wonder if you could just share briefly with us your proudest moments in those two great responsible roles.
Oh, well, I think the proudest moment for me as a midwife prior to becoming one of those chiefs was the services that I supported for asylum seekers and refugees accessing maternity care. And that was me down at the Refugee Council in Brixton, making it my business to ensure that every woman who couldn't get access got access through me. I broke through a few rules along the way, but for a good reason. And I was only on the naughty step for a little while. But the most important thing was that women received timely maternity care in an equal way. In relation to my work as a chief midwifery officer, I think one of my most defining moments, I think, was to build an infrastructure for the rest of the midwives in England, the 24,000 midwives in England. So I built, designed job descriptions, worked hard on business cases to build an infrastructure that meant, as the chief midwifery officer, there were 2 deputy chief midwifery officers. There was a regional chief midwife, a chief midwife in each region of the NHS. That was 7. There was deputy chief midwives, and then a region. I supported my obstetric colleague to develop the regional obstetrician post that worked with the regional chief midwife and the deputy. So what I was doing, I was looking at the future and looking at how we could support safe maternity care with additional leadership support, surveillance through this model that I've just described.
Thank you. And you talked about also, Jacqueline, joy and privilege. And of course, there would have been many privileges in your career, having delivered great many numbers of babies. Do you know how many mothers have named a child after you?
Yes, I do. I can honestly say that I don't think that there's any mother that's named their child after me. I think Jackie isn't a name that's a trendy name, I think, for this time. But I do know that a family named their baby boy Jack, and that was in recognition of the fact that their midwife was Jacqueline.
What a joy and what a privilege. Tazzy, you had a question. Let me just bring your question in, Tazzy, and really good to see you.
Really good to see you, and lovely to see Jacqueline today. Thank you. I have a question really, Jacqueline. In terms of those of us in civic life, as well as members of the public who maybe, what would one say, are involved in their community, you know, they do a lot of the community leaders, if you like. What actions can those of us in civic life or community leaders do to help drive up standards in maternity within our local hospitals when it seems that all governance, accountability, and influence is heavily NHS-led and driven? You know, what influence, what mechanisms can we do to hold our local maternity services to account and improved, if at all?
You froze a little bit there, Tazzy, and lovely to see you. And great memories of your amazingness in the maternity team when you were with us. But you did leave. You did leave us on to better things. But onto your question, I think there's lots. Well, I would say that there are a few things that you can do. You know that every trust will have its public board. So I guess there's something about knowing and listening and understanding what's happening within your local maternity or your hospital, not just maternity services, but your hospital. I think there's also the maternity voices partnerships, the MVPs. I know that membership of those is very much focused on women who have had a baby in recent times, but nonetheless, there may well be items that can be shared with the MVPs, the Maternity Voices Partnerships, in terms of raising awareness to them or asking them key questions, and indeed writing to the trust and seeing if there are other ways of getting involved in terms of some trusts have forums, as you know, for people that have used NHS services in one way or another. So I would say just try and engage in the way that you can, but don't be fearful of knocking on doors. And I think if I could tell my younger self something, I would say be bold and courageous and knock on bigger doors. I was bold and courageous, but not enough, I think, to knock on those doors.
Oh, that's really helpful. Thank you. Nice to see you again.
Thank you. Any other questions from anybody? I've got time for one quick question, if there is one.
Councillor.
Yes.
Keaton, it's Sina Jeffers.
Thank you.
I'd like to ask Jacqueline, do you know who is dealing with these women who have died? Because there's lessons to be learned from the death of whether the child or the mom. Who's dealing with that bit of this pregnancy issue?
Thank you.
Yeah, it's a really good question. And in short, as a result of the Morecambe Bay report, the report that I took, 2015, that report was published, there is now something called the HSIB, the Health Safety Investigation Branch in England, and they are responsible for ensuring that investigations into anything that is of that nature are investigated independently, and that independence will then support improvement instead of the organisation themselves investigating their own cases. That's just one example. Also, we have the duty of candour, which is across the NHS, which means that families now must be kept up to date and at pace with everything that's happening with the investigation process. So questions and challenges can be from the families or from people that are supporting the families in that regard.
Thank you very much for that. And Deepa, final question from you, please.
Hi, I just wanted to say thank you for putting it up on Twitter. I'm glad I saw it. My question was, I'm a newly qualified midwife. However, I've worked in maternity over the last 12 years. I've worked in Brent, I've worked in East London as well. And I've come to realize that during the booking appointment, we ask a question about a person's immigration status. And that, I feel, is a barrier in terms of how midwives interpret it, because midwives are not border agents. I've had women, some people say, oh, she's a student, but she's working, without knowing they are allowed to work for a certain number of hours. Or somebody saying, oh, that's an asylum seeker, but they're still not working, not knowing that they are not able to work. Or somebody said, oh, you have no access to public funds on your passport, so you can't access maternity. These are things I've heard over the years. And I'm wondering why, as midwives, do we get into the part of, somebody's immigration status? And I know the government needs it for people who are misusing it, but is there been any discussion around we can put it out at a GP level or, an admin level, rather than a midwife asking that question? Because that booking appointment starts like that sometimes can become a barrier, particularly for women who would not access that service.
Sure. Not sure whether Jacqueline can pick this up, but if not, certainly Deepa will pick this up offline. Jacqueline, thank you very much. Jacqueline, let me just finish with another cheeky question, very briefly. So is call the midwife, do you think accurate for its time, or do you think it's just rose-tinted hindsight?
Well, Call the Midwife is responsible for increasing the number of people that want to be midwives, so that's a good thing. However, I do think there are some rose-tinted glasses there. However, when I look at Call the Midwife, what it espouses for me is community trust, community respecting that pillar of the community that was the midwife. And that's what I see. But times have changed, people have changed, contexts have changed, and here we are today in this wondrous system that we exist in. So yes, a little bit of rose-tinted glasses, but the community spirit, I think, is something that we could foster again.
Thank you very much. Deepa, thank you for your question. We'll pick that up offline, and to all the other colleagues who have asked really beautiful questions, thank you very much. And let me pass you back to Ali. 1 hour, as I say, each month goes very, very quickly, and hasn't it gone so quickly this evening? Again, thank you. Ali, over to you.
Thank you, Ketan. So just to say a huge thank you both to our chair, Ketan, and particularly to Jacqueline. That was really, really interesting. As Ketan said, I feel like we could continue to discuss this for such a long time, and you've given us a lot to think about. Thank you very much. We will be sending out the link to this lecture to everyone who has attended. I know there was a question on the chat about sharing that, so please do, so that other people are able to listen to the lecture this evening. And we'll also send out details of next month's lecture, which we are busy planning at the moment. So thank you again for contributing and for coming along to the lecture. And again, Jacqueline, thank you so much for your time and your thoughts this evening. I've really enjoyed it. Thank you.
Thank you for inviting me. Thank you so much. Thank you.
Thank you. Until next time. Good evening, everybody. Have a good evening.